So a couple of people around me had some symptoms. One had shivering, one had a fainting spell. Both, but were immediately. They both kind of were. They recuperated within a few minutes only. One had to be given injection even. One was given in front of. Yeah. She had a shivering spell. No, just like a shivering spell.
Right.
Very brief. But they didn't want to take a chance.
Compulsory half an hour waiting.
Yes, compulsory half. Some were waiting for even longer.
Oh no. I ran away the moment it was 29 minutes and 59 seconds.
I just ran. I had a lot of. Finished it and
They
just
wouldn't
ran.
give us the report till it was 30 minutes.
Right, yeah. No, even same here.
We will
Yes,
start. So, Dr. Chatterjee, can you just stop sharing so that I can share the flyer?
End show कर दूं?
वहाँ से नहीं, आप just नीचे जाके just go to your
एक मिनट.
हाँ, वहाँ पे just stop presenting कर दीजिए.
एक मिनट. Yeah, I'll go to the Google Meet and then
Just and stop presenting. Just press no, हाँ वो वाला right, left side वाला या stop presenting को दबा दीजिए. ये जो stop presenting
you are presenting जो है ना?
हाँ, उसमें stop presenting वाला दबा दीजिए.
ठीक है कर दिया.
Right, great. So I'll present now and I'll start. Good evening, everybody. Welcome to this evening episode of Pursue. And we are starting Pursue 11, and that's Pursue 11A, which is Endocrine Pathology. We are streaming live from IPGME&R, Kolkata. And today we have two special people, the moderator as well as the speaker. Both are very special. Let me introduce the moderator. We have Dr. Divya Mehta, who is a postgraduate in pathology, a PDF in oncopathology from Tata Medical Center. She is a senior consultant in the Department of Oncopathology with multiple publications in Index National and International Journal, an expert in neuropathology, gynepathology, and soft tissue tumors. Before I ask Dr. Mehta to take over, let me request
So other than that, it has 100% specificity and sensitivity. But the problem is that it's not always available. So then what is available is inhibin, melon A, and calretinin. The three of them together are very good. Inhibin, unfortunately, has a sensitivity much lower, about 70%, 75%. Specificity very, very high. And melon A, calretinin. So if you add melon A and calretinin and do all three together, then you reach a sensitivity of over 90%. Because in our part of the world, metastatic melanoma is very, very rare. But otherwise, in a Western population, yes, melon A, the problem is to differentiate from metastatic melanoma. Calretinin also, when you add it to calretinin is a bit non-specific. But then if you add these three together, it's very good. Vimentin, cytokeratin, yes, Vimentin usually is positive, like I showed you in this case. IGF-2 is another very, very good stain, but that's more of a translational, that would diagnostic and prognostic marker. Atophysine is positive in half the cases of adrenocortical tumors. Now, just to show you cases, this is what now SF1 is a nuclear stain. It's a beautiful, crisp nuclear stain, stains almost everything. Unlike inhibin, which is more readily available, it has a lower sensitivity. It's a bit patchy. It doesn't stain all the cells, but there it is. It's a cytoplasmic and it is less sensitive than the SF1. Now, one of the things you always have to keep in mind when you're looking at an adrenocortical tumor is a metastatic or an infiltration from a renal cell carcinoma lying next door. So this can be histologically they look almost the same. So here comes your immunos. You could do an SF1 if you have it, or inhibin, calretinin, melanate in whatever combination. Along with that, if you do EMA and CD10, that should be good enough to differ similar. Pheo versus an adrenocortical tumor. Now I've shown you these two. One is a pheo, one is an adrenocortical tumor. They both look very similar. Both have a nested pattern. Both have basophilic cells. Both have uniform nuclei with barely discernible nucleoli. They both look very similar with a packeted appearance. But one is an adrenocortical tumor and one is a pheochromocytoma. And as I said, this is the commonest mistake this is the commonest reason for a major mistake as far as adrenal tumors is concerned. Now just make up your mind. I'm going to show you the gross. Actually, the gross is far easier than the micro to interpret. Now that's the gross. Now it's clear as daylight that the upper one is a pheochromocytoma. You can see the yellow cortex in the periphery, and this is a adrenocortical tumor. The yellow areas, the brown areas. This is where you have your rich cells, lipid-laden cells, and this is the pheo. So now when you go back, yes, the first one, the top one is a pheochromocytoma, and the bottom one is an adrenocortical tumor. I'll show you I'll show you this particular case as I go along. So to differentiate pheo and adrenocortical tumor, they have a lot in common. Synaptophysin, neurofilament, neuron-specific enolase, they are all common in both, and synaptophysin is positive in, as I said, in 50% of the cases of adrenocortical tumors. Now, why is it? Is it just because they are lying next door? Does it rub off from the medulla? What is it? But studies have shown that these adrenocortical tumors can have membrane-bound neurosecretory granules. They have mRNA for synaptophysin. So it's not that it's just rubbing off from the neighbor. So they can show some sort of neuroendocrine differentiation. I guess it's something like the MINEN, or if you can have MINEN and the MANEC in the GI tract, you can have carcinoma with neuroendocrine differentiation. Then these cortical tumors, maybe they also show some amount of neuroendocrine differentiation. But to come back to the question of pheo versus adrenocortical, never comes positive in the adrenocortical tumor. So chromogranin is the reliable one here, and SF1 inhibin, which will never come positive in the pheochromocytoma. So this pheochromocytoma versus adrenocortical tumor, you think that it's a joke, but how can that be? But it happens I have seen 3 cases myself, and I'd like to share this with you, that 3 cases I have seen of adrenocortical tumor were to me as a pheochromocytoma, and keep this in mind, that both pheochromocytoma and Cushing both can have hypertension, and even a Cushing's can have marginally raised metanephrites. So even now, in this particular case, the clinician sent half to me and half elsewhere. And elsewhere, where the immunos were done, it turned out to be synaptophysin positive. However, later on, I showed that it's inhibin positive, and the clinician goes, even today, 3 years after diagnosis, he keeps asking me, are you sure that was an adrenocortical and not a pheo? The patient had hypertension, So this is what happens. It happens, these cases, that common hypertension, marginally raised metanephrites, it's sometimes very, very difficult. And it's particularly difficult in cases where there's less lipid and you have a nested pattern. I'll come back to that later. Okay, and even this is a case with eosinophilic globules, and even the eosinophilic globules are not seen. This is a case of an adrenocortical carcinoma with eosinophilic globules. Okay, so once you've excluded METs, once you've excluded pheochromocytoma, let's talk about the cortical tumors, and I'll do the adenomas and the carcinomas together. Tumors, that is IGF-2 overexpression. So now we come to this very important thing. So whenever you're dealing with an adrenocortical entire hormonal profile with you, once you have the hormonal profile, the size and weight, half the diagnosis is made. it does follow a very regular pattern. So let me stress to you that hyperaldosteronism alone, it's only seen in adenomas. You never find an aldosterone secreting carcinoma. Pure aldosterone secreting carcinoma doesn't happen. If there is aldosterone secreting carcinoma, it's along with Cushing's, it's along with something else. It's always a mix. Similarly, a feminizing one is also always a carcinoma, the other end. The other end is the feminizing one. In so many years, I've seen only one case of feminizing. 20 years ago, this was a little girl with precocious puberty, bleeding PV. But this was a 20 years ago case. She did not do well. So feminizing tumors, always malignant. And pure hyperaldosteronism, always benign, always adenoma. Cushing's, half and half. Cushing's, half adenoma, half carcinoma. Then you have a mixed Cushing and virilizing. Again, 99% it's a carcinoma. So the mixed tumors are all carcinomas. Virilizing is usually 70% of the virilizing tumors alone are also carcinoma. Very rarely you have the virilizing adenomas. And with this in mind, and the gross, the hyperaldosteronism, the bright orange color, the Cushing has its yellow-brown color, virilizing, that meaty color. So with this in mind, then you must go on to the rest of the. So just to show you some clinical pictures, this is a little boy with precocious puberty, girl with, again, half. There are 9 things, there are 9 systems, scoring systems which have been listed. Poland team, Helsinki, Weiss, modified Weiss, Weinike, Lin Weiss, half. So this only goes to show that not a single one is perfect. The best one is yet to evolve. Right. So one of the first ones was this half system of differentiating adenoma versus carcinoma. Now this included, in addition to histological, a lot of non-histological like the tumor mass, the gross, urinary 17 keto steroids, response to ACTH, Cushing's with virilism, weight loss, everything. And this was replaced by the Vansgluten, which is very, very good. It has 100% concordance with the Weiss. Only thing it's a little tedious and a lot of sums to do, a lot of multiplication and addition, and that's what it's not easy on a daily basis to remember and do the sums. So then comes the most widely used, the Weiss criteria. This is my favorite slide in this entire presentation. This is Weiss in pictures. This is Weiss criteria. There are 9 criteria. So for symmetry, I have put 8 pictures and I've put the mitosis and atypical mitosis together in this. So there are 9 criteria in this. Each one has 1 point. So you can have 0 to 9 and just add them up. So anything with more than 3 is considered as adrenocortical carcinoma, 0, 1, and 2 being adrenocortical adenomas. Now, why so many? Why do you need to look at so many parameters? For example, in thyroid follicular neoplasm, you're only looking at capsular and vascular invasion. You look at 9 points like this. Now, this is because no single parameter is sensitive enough to distinguish between an adenoma and carcinoma. No single parameter. So you need all these 9 parameters. In fact, when Weiss formulated this, he initially kept it at more than 4 to be malignant. Then it was found that of some cases of 3 also showed metastasis. So he later on lowered his own criteria from 4 to 3. So now it's 3 or more as malignant. Now, this has been shown. Now there are 9 points here. Each one of these has been weighed out. And it has been found that after weighing them out, which are the most important ones? So the most important ones amongst these, it has been seen, is the necrosis, mitosis more than 5/50 high power field, and the vascular invasion. These are the most important points, and it is seen that in the so many classifications that are there, mitosis and necrosis and vascular invasion are there in practically all the scoring systems that are available. Okay, then there is another, so then came the modified Weiss, where the total number is 7, and again more than 3 is considered malignant, and this also includes the mitosis and the necrosis and vascular invasion. But there are limitations of Weiss. Obviously, one size doesn't fit all, and it was seen there are some variants like the oncocytic variant, the myxoid variant, the sarcomatoid variant. So it is difficult to apply the Weiss criteria to these variants. For example, the oncocytic, it overdiagnoses oncocytic carcinoma, especially, and I said that, as I had told you, that there's a peak 0 to 4 years. So in these pediatric patients, using Weiss tends to overdiagnose carcinoma over adenoma. So then came another, this is a very popular thing, the disruption of reticulin framework algorithm. This was suggested by Volanti. So this is a very, very simple thing to do. It's just a histochemical stain. You do a reticulin stain, and if the reticulin framework is disrupted in over 1/3 of the lesion, or you can take it as fraying or thickening over 1/3 of the lesion, that is considered as disruption of reticulin framework, along with any one of the three important features: mitosis, necrosis, venous invasion. So you need to have this disruption of reticulin framework and any one of these to make a diagnosis of carcinoma. Now this has 100% concordance with the Weiss scoring method, and it has a sensitivity and specificity. Many, well-planned studies have shown that this has a sensitivity and specificity of almost 100%. Of course, some people have suggested that instead of a reticulin, if you have, you could do a IHC against laminin or collagen 4. But if not, if you don't have IHC2, which in my department I don't have, then just a reticulin stain is very good. Okay, then we come to the pediatric adrenocortical neoplasms, where I said the biological behavior contrasts morphologically similar tumors in adults. So this is shown very well in this article by Denner, which reads, adrenocortical neoplasms in children. Why so many carcinomas and yet so many survivors? Now he found that in his study of about 100 patients, 90% IHC and the clinicopathological features of 83 patients of adrenocortical neoplasms in pediatric, and came up with another set of criteria. So what they retained in Weiss is the capsular invasion, atypical mitosis, necrosis, and venous invasion. So the last three I told you are very important. These have been retained. What has not been retained is the diffuse architecture, 23%, less than 25% clear cell, and in pediatric patients, the weight and size are very important. So what has been included instead is 400 weight, more than 400 grams, size more than 10.5 centimeter, mitosis. Look at the amount of mitosis that's allowed. In the adult in the standard Weiss criteria, it is 5 mitosis per 50 high power field, which you're counting as 1 point in the Weiss criteria. And here it is more than 50 mitosis per 20 high power field. And look at the weight. So a lot more size, a lot more weight, and a lot more mitosis is allowed in the pediatric neoplasm. They tend to be much bigger. And if you think of it, the fetal cortex tends to be cytomegalic anyway. The cells are much larger, and perhaps these neoplasms in infants could be derived from the fetal cortex, and they tend to be much larger than the adult tumors. Another thing is that in this Weinicke criteria, unlike the Weiss where there's only carcinoma and adenoma, here there's our favorite, an intermediate category, or something like an atypical adenoma. So there's an intermediate category, less than 2 is benign. If you get a score of 3, it's intermediate, more than 3 is malignant. So there is an intermediate category suggested here. But remember, the size and weight are very, very important in case of the pediatric tumors. And in our own study of, about 13 patients, we found that there is a discrepancy between Weinicke and Weiss when you apply it to the pediatric patient. And we also found that Ki67 is very, very useful marker to differentiate the adenoma versus carcinoma. And we further found that IGF-2 is a highly sensitive marker of malignancy in pediatric patients. It's also in adult patients. And it shows this IGF-2, this is SF1, the crisp nuclear staining, and IGF-2. It's not a brown blush that you're looking at in IGF-2. It's this kind of paranuclear huff, it accumulates in the Golgi. And so you get this paranuclear huff, this paranuclear staining, dot-like thing. This is a very specific staining of IGF-2, very specific, and it is specifically shown, and it can very specifically distinguish carcinoma versus adenoma. But of course, IGF-2 is not available readily to us. It's still at a translational level. So with this in mind, I go on to my cases. I'm going to show 10 cases. So this is the first case. This is a 25-year-old lady with hypertension, muscle weakness, cramps, one paralytic episode. She was hypertensive, low potassium, and she had hypokalemia. And the CT scan showed a nodule in the right adrenal, which was taken out. Here I've serially sectioned it. And you see this 2 centimeter bright orange nodule, canary yellow. Straight away, this is a you think of an aldosterone secreting adenoma in this case. Look at this bright orange color, and this is what it looked like. This is the remaining cortex. This is the tumor, and this is the rest of the cortex. Now, if you look at it carefully, the rest of the cortex is not at all atrophic, like you expect, like you get in the Cushing's adenoma. In Cushing's adenoma, the ipsilateral cortex and the contralateral cortex are both atrophic, but not so in case of the aldosterone ones. In fact, it could be hypoplastic like this. And the cells are sort of clear cells, and they are hybrid between the glomerulosa and the fasciculator cells. So, they are larger than the glomerulosa cells, but smaller than the fasciculator cells, full of lipids over here, right? Full of lipids. And you don't need to vice code this one at all. It will be 0/9. I told you they're always adenomas. And this is another case of an aldosterone adenoma in a 30-year-old male who presented with hypertension. But here what I want to show you is that they can be very small. So small that, sometimes only a centimeter or less. So a centimeter, so you need to transversely section them, like very fine sectioning, so that you don't miss that little nodule. And this patient, this is a 10-year-old case. So this patient was treated with spironolactone, and you can see the spironolactone bodies, and that can be there both in the tumorous portion. Sometimes it's more in the non-tumorous portion, as you see here. It can be there in the tumorous portion, but it can be there in the non-tumorous portion. Here are the spironolactone bodies surrounded by a halo. Yet another case of a bright yellow aldosterone secreting adenoma, and about 60% of them are associated with mutations of KCN5 gene. Now this is a potassium transporter, and the ones with KCN5 mutation tend to be a little larger, more severe hypertension than those which do not. Okay. So with this, I go on to the Cushing's one. So now I've shown you three cases of aldosterone secreting adenoma. So now I'm going to show you the non-aldosterone secreting adenomas and the carcinomas. So now I'm going to show you. So this is a collage of 3 cases of adenomas. So the cross, it's very this one there was rupture during during operation there was rupture. So, but this is also very uniform looking. Note that no necrosis. Look at this one. This is the same one. No necrosis at all. It's meaty, fleshy, pink in appearance. This one also, it's uniform in appearance, the adenoma, as compared to the gross of this collage of 4 carcinomas. The carcinoma, look at the necrosis here. There's necrosis here as well. And look at this coarse nodularity. And this coarse nodularity is this anybody can say that this is a carcinoma. But in this one, look at the coarse nodularity here, This coarse nodularity is very, very typical of the adrenocortical carcinomas. This was a mixed one. See, this is a meaty in appearance, very meaty, and this is a virilizing carcinoma, and this was a mixed Cushing and virilizing one. This also, I think, was a mixed one, and this was a non-secretory one, as far as I remember. So let's look at some Cushing's now. This is a baby, 6-month-old baby with Cushing's, and she had raised cortisol. Her TRS was normal. There was no virilization. The TRS level was absolutely normal. And this is what her tumor looked like. very uniform, but the size is a little larger. Just remember, in adults, whenever you find a Cushing's more than 100 grams, be very wary. Take multiple sections to rule out a carcinoma. But in case of a baby, as I told you, more weight and size is allowed in any case. So 4 centimeter, 130 grams, and this is what the microscopy looked like. And this is the case, and this is exactly the case I showed you as a teaser. This is the case I showed you as a teaser with the Pheochromocytoma. So look at the nested pattern. It's very nested. A uniform nuclei, uniform. So if you were to Y-score this one, the only point that you can get is lack of 25% clear cells. So that would make it 1 out of 9 Ys, which is absolutely benign. And the reticulin is beautifully preserved in this case. And here it is. So this is a cortisol secreting adenoma. And this is the child after 6 months. She's done, not after, I think, 2-3 months. She's her Cushing and everything is gone. As I told you, in the aldosterone secreting adenoma, you can have ACN mutation. Here there are activating mutations of protein kinase A in about 40% of the cortisol secreting adenomas. Okay, then you can have some morphological variations. You can have morphological variations in the adenoma in the form of lipoadenoma, myelolipoadenoma. So this is a Cushing's lipoadenoma. You can have a lot of fat here, but that's of no significance. You could even have a myelolipoadenoma. There's an entity known as a black adenoma. I'm yet to see one where you have a lot of lipofuscin, but there's no black carcinoma. But black adenoma, lipoadenoma, myelolipoadenoma are just variations on the adenoma. So now I'll show you another case of a Cushing's. This is my 4th case. That was a 6-month-old girl with Cushing's adenoma. This is a 16-year-old girl with Cushing's. Her cortisol levels were raised. TRS was normal. So it's a single hormone secreting. Rather big, 170 grams and 6 centimeter. Because it was 6 centimeter, it ruptured during taking out. So here it is. It's brown in color. And if you look at the microscopy, beautiful capsule. Okay, beautiful capsule, diffuse architecture. There are no clear cells, no mitosis, no capsular invasion, venous invasion, no atypical mitosis, no high nuclear grade. All the nuclei look the same, more or less. So I would say that 2 out of 9, which makes it benign, really, doesn't it? So it is lack of clear cells and loss of the packeted appearance or the loss of nesting, sort of diffuse architecture. So this is why 2 out of 9, but yet it is 170 grams. And I decided to do a reticulin stain, which definitely shows lack of reticulin staining, disruption of the framework in more than half the slide. Ki67 was very, very, very low. So what do you do about these cases? Now if you go back, I'm getting 2 out of 9. Now if you look carefully, I searched and I decided to call these nuclei maybe Fuhrmann grade 3, focally. So let's call this a carcinoma then, much to the displeasure of the clinician who kept saying, but madam, this is a single hormone secreting, so don't get lured into that. The pure Cushing's half the pure Cushing's are carcinoma and half the pure Cushing's are adenoma. So I want to stress to you, you can have a pure Cushing's carcinoma. Pure Cushing's are not always adenomas. And this was true, but much, much, much later I did an IGF-2 on this case, which shows that beautiful paranuclear staining. Now, as far as so I did call this an adrenocortical carcinoma, low grade. The Ki67 is very low, less than 5%, and as far as grading is concerned, which is done by mitosis, more than 20 per 50 high power field, or less than 20. This was far less than 20 per 50 high power field. So low grade carcinoma, she does not need mitotain, but just a follow up. But this is to stress to you that there are these borderline cases which you can't fit into any category. So there will be cases like this which are difficult to fit into any category, and this is where the problem comes. And because as of now, there is no borderline or an uncertain malignant potential category. So with this, let's look at another Cushing's now. Cushing's, this is another man with Cushing's, 60-year-old man with puffiness, abdominal obesity, bipedal edema. The tumor is about 6 centimeters and weighs 200 grams. Now, in this case, both TRS and cortisol are raised. It was so big that half of it was sent in a bowl, so you had to weigh the two together. So there it is. So let's look at this. There is necrosis here, 1/9. And if you look at this, lack of clear cells, straight away 2/9. Diffuse pattern, 3/9. Look at the high nuclear grade 4. That would make it 4/9. Sometimes these adrenocortical carcinomas can have a very, very high. This is from a different case, but just to stress to you how bad they can look. These monster-looking cells. Sometimes they can look as bad. Now let's go back to my case. There was capsular invasion, 5/9. So this is straight away a carcinoma, which is there was of course disruption of reticulin framework. The Ki67 was rather high, so this is a mixed virilizing and Cushing adrenocortical carcinoma, high grade, where the mitosis was more than 20/50 high power field. So this is a mixed one. Let's look at another virilizing one. This is a 17-year-old girl who came with oligomenorrhea, hirsutism, a deepening of voice, loss of scalp hair, and a lot of acne. Her TRS was raised, testosterone is raised, cortisol levels were normal, 6 centimeter, 200 grams, just like the previous case. The previous case was also 6 centimeter, 200 grams. This is also 6. Look how meaty it is. Actually, the sex steroid secreting tumors tend to be larger and more brown in color. So this is what, if you look at this diffuse architecture, straight away 1/9. Here, you can find high nuclear grade, again 2/9. There is necrosis here, 3/9. So this is a virilizing carcinoma. So virilizing, the pure virilizing adenomas are quite rare. I'll show you another virilizing tumor, and the Ki67 was also quite low. So I would call this a low-grade adrenocortical carcinoma, and this is a pure virilizing one. Another virilizing tumor, this is a 1-year-old baby with precocious puberty. He had, look at his muscles. 3 people needed to hold him to take a blood sample for the testosterone and the aldosteronoma levels. He had so much of muscle power in him at that point. So this tumor, if you look at it, look at the necrosis, a meaty appearance, and look at the necrosis. I've shown you this before when I showed you a collage of 4 cases of adrenocortical carcinomas. So there, this is what it looks like. So necrosis, straight away you've got 1 out of 9. So here, if you find there's a diffuse pattern, 2/9, high nuclear grade, 3/9, 4/9, there is atypical mitosis here, and sort of capsular invasion, I would call that a 5/9, right? So by Weiss criteria, so it's a 5/9. But if you use the Wernicke or the pediatric one, then it's much lower, because size and weight are far below 400 grams and 10.5 centimeters. There is atypical mitosis. Then there is tumor necrosis and capsular invasion, which puts it into this 3/9 or an intermediate category. So this is what Denner refused to refer to as the virilizing atypical adenomas. So it is important, because what do you do here? Do you treat with mitotane, which is a very, very, do you give radiotherapy in a baby? Do you treat with mitotane in a baby, which is very, 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 very toxic? This child, after resection, was followed up, and he is doing very well. It's 5 years now, since more than 5 years, and this child is absolutely fine. But this is just to show you the discrepancy between the 2 scorings. That's what I'm trying to stress to you. Now, we have another case here of a 40-year-old lady. She had no endocrine symptoms at all. She came with abdominal fullness, dragging pain, huge mass, right, with extra adrenal extension. You can see that it's come out piecemeal, and she had liver mets. It's a huge tumor, 12 centimeter and 600 grams. This is what it looks like. It doesn't even look like adrenal, doesn't it? There are these cells here which are pretty low, which show low nuclear grade. And here there's plenty of myxoid material, extracellular myxoid material, which is sort of filling up the whole slide. And of course, there was extra adrenal extension, this capsular extension here, as you can see. This is a Alcian blue stain, and this entire extracellular myxoid material. It's pretty, isn't it, the Alcian blue stain? It looks so pretty. So here it is, the Alcian blue stain. And in a case like this, you can have a lot of retroperitoneal myxoid neoplasms. So I would do an inhibin on this. And inhibin, here it is, it's inhibin positive. Surprisingly, it's a little bit synaptophysin positive. I told you that 50% of the adrenocortical tumors can show synaptophysin positivity. In my experience, it's less than 50%, but they can show patchy positivity. But there's a strong inhibin positivity here. Ki67 is quite low. So this is a myxoid adrenocortical carcinoma. There are some variants. I told you there are some morphological variants: the myxoid, the sarcomatoid, and the oncocytic. So these myxoid variants, they tend to do much worse. The Y score tends to be low. There is not much mitosis here. But however low the Y score may be, the myxoid ones don't do very well. So there are not enough case reports, there are not enough series of myxoid tumors. So in whatever myxoid tumors, I will just show you one or two more articles on this, but I want to share with you one more myxoid tumor in a baby. This is a 6 months old with a huge mass, completely non-secretory. The myxoid ones, they again tend to be non-functional. So this was the tumor. You can see a tail of adrenal here, and here is the tumor. This is what it looks like. Look at the myxoid material, the strong Alcian blue and the pseudo-glandular pattern that you can see here. So this is a myxoid adrenal adenoma, and applying the Weinicke, nothing is present. There's no extra-adrenal extension, there's no vena cava extension, there is no capsular venous or vena cava extension. Mitosis absolutely zero. So I call this an adenoma after a lot of, I was scared in calling this an adenoma because it's myxoid, but it's 7 years now, child is doing very well. And I like to stress to you that myxoid tumors are usually seen in adults, they are non-functional. The proportion of myxoid stroma can vary from 10% to 90%. Both these cases are over 90% myxoid stroma, but a few reports show that myxoid is associated with aggressive behavior, and the malignant potential of these tumors is not clear. So in this article, adrenocortical tumors with myxoid features a distinct phenotypic variant exhibiting malignant behavior. So this was 14 cases and all adults. And here's my case, the adenoma in a child, an unusual morphology. So other than myxoid, you can have, this is my only book picture here. I'm yet to see a case of oncocytic. There's one more variant, the oncocytic variant. Now the oncocytic variant tends to be larger, and for obvious reasons, the Weiss criteria tends to overdiagnose because there are no clear cells. They're all granular cells. They tend to be larger. They show a diffuse pattern, they show high nuclear grade, and they show lack of 25%, and there are no clear cells at all. So for oncocytic, it was decided it was then decided the Weiss criteria doesn't work because majority, they are non-functional. And so what was, it was seen that the size and weight are again important. So Lin-Weiss-Pisciglia criteria, there's another set of criteria where you take gross and microscopy into account. And these, just remember that the oncocytic variant tends to be larger, it tends to be non-functional, and they must be differentiated. And you need one major or 4 minor to call this an oncocytic carcinoma. Majority of the oncocytic tumors are benign. Majority of the myxoid tumors are malignant. There's yet another variant, and I'm yet to see one, and that is the sarcomatoid variant. But then again, the sarcomatoid variant, it would look like a carcinosarcoma. And again, you need to put your adrenal panel, that's SF1, inhibin, melon A, and calretinin to prove that it is of adrenocortical origin. And some people have commented on presence of this rhabdoid variant, but which is not accepted in the WHO. You don't find a rhabdoid variant, but I've shown you many cells which look a bit rhabdoid. But this rhabdoid variant has nothing to do with rhabdoid tumor. There's absolutely no INI1 loss. INI1 is beautifully written. It's something like it's just a morphological variant, they say. It's like the rhabdoid tumor, it's like a rhabdoid meningioma, where the INI1 is retained, but that's not accepted anywhere, rhabdoid variant. So, at a practical level, when you're trying to distinguish adenoma versus carcinoma, I want you to remember, you will come across cases where the distinction is not so clear-cut. So at a practical level, mitosis, necrosis, and vascular invasion. These are the 3 most important points. In addition, in the pediatric cases, The tumor size and weight are very important. Less than 200, likely to be benign. 400 to 200 to 400, it's variable, and more than 400 likely to be malignant. But this is in pediatric. But of course, every now and then you'll come across cases where size and weight are in that in-between category. So these are cases where the clinical features, that is the endocrine profile, the gross, the microscopy, IHC, and molecular profile, everything comes into consideration when you come to these borderline cases. So the prognostic features, the main thing is the clinical staging using the NSAT. The NSAT staging is the one which is European Network for Adrenocortical Tumors. That's the one which is size and weight are of course important, especially necrosis, mitosis. And based on mitosis, there's a suggested high grade and low grade. As I have said, the high grade ones having more than 20 mitosis per 50 hypophoebe. Then again, Ki67 index more than 5% or less than 5%. And to this, I would add IGF2 and SF1 overexpression are also associated with a worse prognosis. And based on the molecular, there is a new emerging molecular classification of adrenocortical tumor based on the microRNA profile, the methylation profile, the IGF2 overexpression, the beta-catenin activation, and the CpG island hypomethylation profile. So based on that, there's a new emerging classification of the adenomas and the carcinoma. Again, there's a poor prognosis carcinoma and a good prognosis carcinoma. The poor prognosis carcinoma tend to show a different microRNA profile, increased IGF2 expression, and beta-catenin activation as compared to the good prognosis. This is important because, it will help us, because one day it will lead to, targeted therapies to be developed. But this is still at a translational level, the emerging classification. Now I just come to my last case. I've almost finished. So that is incidentaloma. I'm just going to show you one case of adrenocortical tumor and FNAC. Now, incidentalomas, as you know, there's an increased incidence of incidentalomas today because of rampant, and these are tumors which are discovered incidentally for CT MRI done for non-adrenal causes, not related to hypertension, not related to CVA. There is no evidence of, steroid hormone excess, and these are found in 20 to 25% of autopsy cases, especially in the elderly, in patients above the age of 50. Majority of these incidentalomas, which are just discovered, are benign. And the workup includes, there's a flow chart, the workup, it keeps changing. But basically tumors which are less than 3 centimeters and they have a fairly high lipid content and a low Hounsfield unit, they are just, you just wait and watch them. But because of these incidentalomas, more and more of FNACs are going to come to you, and you're going to see more and more of FNACs of the adrenal. Now, FNAC of the adrenal SON is a separate story altogether. So that I have to do another day. I can't. But I just want to show you this case. This is a 6-year-old child who presented with a rapidly enlarging abdominal mass. So, and it was an adrenal lesion. So one of the things they thought of was a neuroblastoma. It was arising. She had no Cushing's. There was no calcification. She had hypertension. Urinary VMA was absolutely normal. It was the huge lesion. She had pulmonary Mets as well. Mild increase in serum cortisol and a USG guided FNAC was done, and this is what it looked like. So there are these clusters of cells with a lot of cytoplasm, right? Neuroblastoma is obviously out. There's no question of neuroblastoma in this. So you'll see this foamy background, this lipid or foamy background that you see in this is very characteristic of adrenocortical tumors, that is to have this lipid in this background. And then there were some giant cells like these, and also there was one mitosis here, and there's a lot of nuclear pleomorphism, as you can see. Now this is the matching. I did manage to make a cell block, and the cell block was inhibin positive. So an adrenocortical tumor. Carcinoma, adenoma, very difficult to say on FNAC alone. This is yet another case of an adrenocortical carcinoma. This is a more clear-cut one. There are nucleoli here, and if you look at this H&E stain, look at the prominent nucleoli and the multinucleated giant cells. lot of granular cytoplasm. And in this case, this was a cell block, SF1, reticulin disrupted, IGF2. No, it wasn't done at that time. I did all this much later. But it is possible to do these stains. It's possible to do a reticulin. But see, if the reticulin is lost, it's good. But if it's maintained, it doesn't rule out the carcinoma. Anyway, then there's the IGF2 overexpression that I've done on a much later in these cases. So this is the largest series of fine needle aspiration of adrenocortical tumors. This is a series of 9 cases only, where they found that hypercellularity, necrotic debris, nuclear pleomorphism, moderate to marked mitotic figures and prominent nuclei. These are usually there in case of carcinoma, but a very well differentiated carcinoma is impossible to distinguish from an adenoma on FNAC. So this is our own series of FNAC of the adrenal 50 cases, where we had only 4 cases of adrenocortical carcinomas, and we also found it's really hard to tell between carcinoma and adenoma on FNAC alone, where you don't have the advantage of your capsular invasion, diffuse architecture, vascular invasion. You don't see these features. So it's a bit difficult, but you can make out that this is but you should be able to diagnose adrenocortical tumor and suggest whether it's a carcinoma. It's important because sometimes these patients are given preoperative mitotane, which is very toxic. So the clinician wants to know that is this adrenocortical carcinoma? If it's a carcinoma, sometimes in inoperable cases of preoperative chemotherapy is given in some of these cases. So my take-home message today is adrenocortical tumors should be distinguished from the medullary tumors as well as the metastatic carcinoma. Benign and malignant is a hard job. Though it is widely used, it has its limitations, especially in pediatric cases, and the morphological variants like the oncocytic and the myxoid. Disruption of reticulin is a very easy, simple, useful aid. And one day, with the help of genomic, transcriptomic, microRNA and DNA methylation profile, you will be able to separate them perfectly. Thank you.
Wow. Let Dr. Divya come in and let her say something.
So should I close the screen now?
Yeah, you can close the screen and stop sharing so that we can see your screen. Yeah, and Dr. Divya also. Right.
Take it?
Stop presenting. Just press stop presenting.
Achha.
Yeah.
Okay.
Thank you, madam, for this excellent slide seminar. Thank you for sharing your treasure of adrenal tumors with us and for updating us on the latest emerging molecular classification of adrenal tumors. And if there are any questions from the viewers, I will be happy to ask them. Sir?
There are no questions yet on the YouTube. If there are any direct questions from the Google Meet, people who have joined in, they can unmute and ask, and you can moderate. There are only comments on YouTube. Dr. Manoj Chaudhary has commented. Excellent cases, very good discussion. Dr. Asaranti Kar said, very nice discussion, excellent presentation.
Thank you.
Is there any questions on the Google Meet? Dr. Divya can take from there.
Any questions from our viewers for madam? Madam, I had a question while they are thinking in their head. Can I go ahead and ask? What is the cutoff age that you consider for pediatric versus adult?
It's 18, right?
Okay.
And for everything else, it's 18. But majority of them actually.
So whenever there is an 18-year-old,
infantile ones, the majority are below the age of 4 years actually. Between 4 and 14, you don't see that many. Then again, you see between 15 and 25 girls with virilization. But majority of the virilizing ones or the Cushingoid ones, those are all below the age of 4 years.
Suppose you get a patient at 18. Suppose you get an 18-year-old. Where would you put that patient?
Right. It's very, very difficult. As I said, you take everything into account. The standard WISE criteria, the one which is used everywhere. But of course, as I told you, sometimes, you get these borderline cases, and the clinician is pushing you. It's a single hormone. It's a single hormone. Why are you calling it a carcinoma? So don't get pushed by the single hormone, and so it's a carcinoma. So it's an adenoma. Don't get pushed by that. So you have to look at the size, the weight, and everything. The histologic features, the 9 points which I have elaborated. So look at everything before you make a diagnosis of carcinoma in an 18-year-old. So usually, but again, the hormonal profile is very important. If it's a virilizing one, if it's a Cushing plus virilizing, it's very likely to be a carcinoma rather than a adenoma. And of course, the disruption of reticulin framework, it's very, very, very useful and so easy
Absolutely.
to do.
Absolutely. So having a basic stain rather than is much more useful before one applies the immunohistochemistry.
Yeah,
and your experience with SF1,
IGF-2 is not available to one and all. So this is a very useful stain to do. There are some studies which say that even increased expression. I don't understand this, but there are multiple studies which say that increased expression of SF1 is associated with a worse prognosis, which doesn't make sense to me, because you think that the better differentiated the tumor is, the more SF1, the better it should be. But it's not like that. I don't really understand the reason. But a lot of studies have shown, and we have also seen the same, that the increased expression of SF1 is associated with a worse prognosis. IGF-2 I fully understand, but even SF1 is associated with a worse prognosis than those which have a lower expression of SF1. In fact, the adenomas show a lower expression of SF1 as compared to the carcinomas. I don't know why.
That's really interesting, and I'll be very interested to take the SF1 clone for you, really, because I'm interested in gynae pathology for sex-caused stromal tumors. So I'll be bothering you with the clone for SF1 which you have used.
I'll send it to you on WhatsApp. I think it's Master Diagnostica or I can't remember, but I'll just take a picture and I'll send it to you. Absolutely.
Thank
and
you
it's
so
a very
much,
easy stain. It's a very easy
A
stain.
nuclear stain is always better. A nuclear stain is always better for interpretation.
I've tried this out on granulosa cell tumors, juvenile granulosa cell tumors. It works. Absolutely, juvenile granulosa cell tumor versus germ cell tumor. This is a common problem, right? So in these cases, SF1 inhibin is very good, but so is SF1.
Right. Wonderful, ma'am. I think this is what we're going to do next. Next, we have SAL4 in our institute for germ cell tumors, and SF1 is what I was looking at. And this has been a great opportunity for me to know that you've been doing this, and I will be contacting you soon for help on SF1. If there are any more questions from our online viewers, any questions? So, do you have any questions for Madam?
I would like to just say something. One is a comment on the YouTube. Dr. Sunita Ahlawat says, excellent cases, Uttara.
Oh, thank you, Sunita.
Yeah, she's there. What I would like to say something which is very important in all these adrenal lesions is that one, as rightly pointed out by Dr. Uttara Chatterjee, is that you need to look at the gross.
Absolutely.
It makes a lot of sense, to look at the gross, because many a times the gross feature will give you a clue to what would be coming out, because there's a very distinct gross, representation of these tumors, and their color are very different from one to the other.
Absolutely.
So at times when you don't have access to all the immunohistochemistry and you are in a fix, it's always better for the younger crowd to go back to the grossing room and take it out and have a look at it. It gives a lot of help in trying to, decide one over the other. And Dr. Mamata Guha Malik says, excellent presentation, learned a lot.
Thank you, madam. And I'd like to say, Dr. Nadeem, that what you said, gross is so important. And even in case of a Pheochromocytoma versus adrenocortical tumor, like I showed you, it's gross which clinches the diagnosis.
Yes.
You don't even need a chromogranin at that point. And you said bright orange for aldosterone secreting one, and a yellow for pushing, then a brown for the sex steroid. Even that is helpful to some extent. Yes, of course.
Yeah, I make it a habit to see the gross of all the adrenal tumors, all the renal tumors, before, exactly thinking and going ahead with what exactly it looks like or what it should be. And I think the younger faculty should also look at that. It's very important. Any more comments from anybody, Dr. Divya, if you would like to have a last go?
It's been an excellent talk, madam. I mean, I don't do that much of endocrine pathology, but I have really enjoyed your talk. All your the comparisons between all the scoring systems, especially the talk on the slide on the emerging molecular classification of adrenal tumors.
Yeah,
It's a
yeah.
very enlightening page, which all the youngsters can also take a lot of lessons from that. It's been a great talk, ma'am, and each of your lectures is always, as I said, I'm a huge fan of yours. Thank you.
Thank you so much.
Yeah. Thank you, Dr. Chatterjee. Excellent presentation. Wonderful collection of cases. Brilliantly done. Wonderful, I would say. It's a real learning experience with all what you showed us. And the ones who would be seeing the YouTube presentation on the YouTube as a recording, they will learn a lot. Thank you so much for consenting to give a talk on this platform. We were really, honored to have you here. Thank you so much, and we definitely would request you to come again on another topic. We will discuss it out on some day and then fix up a
I'd like
time.
to continue with the adrenal.
Yeah, sure,
FNAC.
absolutely.
I'll do the FNAC sometime.
Oh, yes, why not? Right. So, thank you so much, everybody. Thank you, ma'am, again. Thank you, Dr. Divya, for consenting to
Thank you, sir.
moderate out time from your such a busy schedule. And thank you, everybody.
Always a
God bless you.
pleasure.
Good night. Take care. And before I leave you, let me just tell you one thing. Wednesday, 7:30, Dr. Dhanpat Jain from US. He is coming
Great.
on live with approach to diagnosis of gastric polyposis.
Wow.
So please join in. He would be there for about 1.5 hours and would love to take direct questions, any clarifications. He'll be taking two lectures, one on this Wednesday and the one on the next Wednesday. So love to have all of you there. Thank you so much for joining again and again on this platform. Thank you so much. God bless you. Good night.
Thank you. Bye bye. Bye, madam.
Bye.